is at 7 p.m. So today I have come to meet you guys, and I have come with the concept which is like I'm going to discuss one topic, that is front of thigh. So I am going to start now. Can you please acknowledge, is everything fine at your end? Audio video is fine? Should we start? Very good evening everyone. So should we start now? Yes? Okay. So I'll be starting with this question. Okay, so that is the question. Read this question carefully. That is a 36-year-old patient reports her condition characterized by tingling, numbness and burning and in the outer thigh, and the diagnosis has been made by you, that is myalgia paresthetica. We know different conditions are there. Chiralgia is there, myalgia is there. So now which nerve is involved in this condition? What is your answer, dear friends? What is your answer in this question? The answer to this question is straightforward. That is lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. But before writing this answer, can you please tell that what is the answer for the chiralgia? Because we have one condition, chiralgia paresthetica, which is usually observed when the nerve in the roof of anatomical snuff box gets compressed because of maybe tight band or something, right? That is superficial branch of the radial nerve, right? But anyway, this branch, lateral cutaneous nerve of thigh, where is this branch? This branch is actually present at the upper angle. It's like upper angle of this femoral triangle part, and this nerve gets compressed sometimes, and the features will be felt of the nerve compression, tingling, numbness, etc., burning, etc., and that will be on the outer aspect of the thigh. And dear friends, this particular nerve, it comes from where? This nerve is a branch of lumbar plexus. This nerve is a branch of lumbar plexus. You can see these are the branches from the lumbar plexus. So let us first start with the lumbar plexus itself, okay? And we will be now writing the mnemonic to remember the names of lumbar plexus branches. And after that, I will show you all the branches here in this diagram. We will come back to this diagram again. And after that, we will be starting with the front of the thigh, okay? So let us now start, and we'll make this lumbar plexus. So dear friends, we have a mnemonic to remember the branches, okay, for the lumbar plexus. And the mnemonic goes like, those who have attended the live classes, they might be remembering. Do you remember the mnemonic here for the lumbar plexus? So we have this mnemonic, that is Ilyas gets late. This is late, L-A-T-E. Please read it carefully, okay? Ilyas gets late on Friday lunch. And what is the meaning? So for the Ilyas, we have this two nerves are there. That is iliohypogastric is there. Iliohypogastric and ilioinguinal. Then we have genitofemoral nerve. And lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. Then we have obturator nerve and femoral. This is lumbosacral trunk. Now, dear friends, although we have written this mnemonic that Ilyas gets late on Friday lunch, and we are including the lunch also here, but let me tell you that lumbosacral trunk is not a part of lumbar plexus. Then what is this? We can simply remember lumbosacral trunk is nothing but L4, L5 fibers are there, which will join with the S1, S2, S3 fibers to make the sacral plexus, is that okay? Now we have rest of the nerves, which are the branches from the lumbar plexus, and it is very easy to remember their root values also. How? We can divide the total 6 nerves into 3 groups, like 2 nerves in each group. So first group, both of them are having the ilio word, and it starts with the letter I. I looks like 1, so both of them are having the root value 1 1. So this will be L1, this will be L1. Next 2 will be like 1 2 2 3, and the last 2 in this group again same, that is L2 3 4, L2 3 4. So we can remember very easily L1, again L1, then 1 2 2 3, 2 3 4, 2 3 4. Did you understand, beta? Did you find it easy and like easy way to remember? Now if you can tell me, obturator and femoral, both of them are having the same root value, but one of them is ventral division. Which one is ventral division? Is it the femoral or the obturator nerve? Now if we see the femoral nerve, what is the position? Is it in the ventral aspect of the thigh or the dorsal aspect of the thigh? It is present in the ventral aspect of the thigh. But if you apply this and you think that it is present in the ventral aspect of the thigh, then it should be ventral division. That's not true, because it is like when the limbs rotation is taking place, the lower limb rotation takes place in just opposite manner when compared to the upper limb. So the position of the femoral nerve is ventral, even though it is actually a dorsal division. So obturator nerve will be the ventral division, and the femoral nerve will be the dorsal division. Now that we have understood this, let us go back to the diagram and let us identify each and every structure over there, and after that we'll be starting with the thigh. Now in this diagram, what you can see, let us identify together. I'll be asking, and if you can tell, try and answer, okay? And if you are actively participating in the class, then the chances are there that you will be retaining this concept for longer duration of time. Is it okay? So you see, this is the bone sacral. So these are the lumbar vertebra, correct? Now can you tell me what is this muscle over here? This will be iliacus muscle, and by the side of lumbar vertebra, what is this muscle over here? This muscle is psoas major. Now iliacus and psoas major, when they come down, they enter the thigh, they will be traveling together as a common tendon. What is the name? Iliopsoas. And psoas major is actually pierced by this nerve, which is genitofemoral nerve. Now on this side of the picture, we can identify the nerves. This nerve is T12 nerve or the subcostal nerve. This is the L1 nerve, that is iliohypogastric. This one will be ilioinguinal. Now here the muscle has been cut. If the muscle has been cut, this nerve also got cut. This is genitofemoral nerve, and this nerve in the superior angle of the femoral triangle will be lateral cutaneous nerve of thigh. This huge nerve over here is the femoral nerve, whereas this nerve will be obturator nerve. Let me tell you, there will be 2 hints for the obturator nerve. If at all you get a question, one hint will be with respect to the pelvic cavity. They will give some pelvic tumor, maybe bladder tumor or something. That hint will be that it is getting compressed in the pelvic cavity itself. And second hint will be it will be passing through the obturator foramen, okay? And then they can ask you like which compartment of the thigh it is present. It's obviously medial compartment. So what action of the thigh will be lost if this nerve is compressed? Then obviously adduction will be lost. So far so good. Could you understand all these parts? Yes. Now dear friends, beyond that, if I describe that, we all know this part is the ASIS, this is pubic symphysis, this is pubic crest, and this is pubic tubercle. Between ASIS and pubic tubercle, you can see the inguinal ligament is attached, correct? So with this basic understanding, let me make this is ASIS, anterior superior iliac spine, and here we have, this is what, this is your pubic symphysis, this is what, pubic crest, and this is what, pubic tubercle. And here you can assume this is midline, that is linea alba, Now between ASIS and pubic tubercle, we have this primary attachment of the inguinal ligament. This is inguinal ligament. But beyond this primary attachment between ASIS and pubic tubercle, it will give three extensions. So it will give three extensions, which we can remember like this. We have A, this one, B, this one, and C, this one. What is A? A is the lacunar ligament. What is B? B is pectinate ligament. And what is C? Is the reflected part of inguinal ligament. Reflected part of inguinal ligament. Now, just for sake of explanation, if I say, you just consider this as a ray of light. If this was ray of light, then this will hit the surface and it will reflect back like this. Do you understand? So it is getting reflected, as if it is getting reflected. That's why C is called as reflected part of inguinal ligament. Inguinal ligament has got one more name. It is called as Poppert ligament. Inguinal ligament is also called as Poppert ligament. Making sense? Okay. Now I'll make this diagram. In this same diagram, I will be adding this muscles to make the diagram for the femoral triangle. But just before that, because we have learned one aspect of it, that is three extensions of the inguinal ligament. Let me show you these extensions. Right here you can see that we have, this is the ASIS point. Everyone please pay attention. And this is pubic tubercle point, and this is inguinal ligament. I hope that makes sense. And after that, it is giving one extension over here, that is lacunar ligament, and this extension, that is pectinate ligament, and this extension, that is reflected part. Making sense? Let me show you one more image with respect to bone, because when we say this part is present, no, this is what ASIS, this is what pubic tubercle, but after it comes to pubic tubercle, you can see this line. This is pectinate line. So on this pectinate line, if some extension of the ligament is going on, that will be called as pectinate ligament. Do you understand now where exactly is the pectinate line and where exactly this pectinate ligament is present? Is it making sense? Now if I show you the same thing in this particular, from frontal view, we can see this is ASIS and pubic tubercle. So this is our inguinal ligament coming. Beyond that, it gives one extension, this lacunar ligament, one extension which goes on the bone, pectinate line. I have shown you the pectinate line which is inside present. That will be the pectineal ligament. Now please confirm. I have shown you these images from different angles, like from front, from above, right, and in a schematic manner. Did you understand? This is what, if I ask you, what is this where I am putting the arrow? What is this ligament? This is inguinal ligament. And what is this ligament? This is lacunar ligament. And what is this ligament? This is pectinate ligament. Could you understand? This arrangement is okay? Yes, Dr. Neha, that is very good suggestion, and I am planning to do it in the coming days, right? So now that you have understood at least this point, that we have the three extensions and how exactly they are present, because in the schematic way we make the three extensions like A, B and C, but exactly how they are present on the bone. I hope that is clear in your mind. Yes? Yes, in a way that is true, Harshit. You can say that. That pectinate ligament, the complete name is ligament of Cooper. इस दिस वे इसको हम पेक्टिनेट लिगामेंट ऑफ कूपर भी बोल सकते हैं, ठीक है. दिस इज कॉल्ड एज पेक्टिनेट लिगामेंट ऑफ कूपर. यहां तक आप लोगों को क्लियर हुआ एवरीवन? ये पॉइंट क्लियर है? नाउ इफ वी ऐड लाइक इन दिस ASIS, which muscle is present? We know that in the ASIS this muscle is present, like this is sartorius muscle is there, and in the like medial aspect we have adductor longus. This is the sartorius. So this becomes the boundary for this femoral triangle, where we have sartorius one boundary, adductor longus another boundary, and the inguinal ligament which makes the base. Is that all okay? But what is the content over here? For the content we can consider that we have a sheath over here. This sheath is called as femoral sheath, which is further having three compartments. Is it making sense? Now if you say we have in the middle compartment this vein, that is femoral vein. Lateral compartment we have this artery, that is femoral artery. And with the femoral artery we have small nerve present. Is it the femoral nerve which is present with the femoral artery within the femoral sheath? The femoral nerve, is it a content of the femoral sheath? Yes or no? No, it is not the femoral nerve. If it is not the femoral nerve, then what is this? This is nothing but the femoral branch of genitofemoral nerve. Then where is the femoral nerve? Where is the femoral nerve? The femoral nerve is, it is outside the femoral sheath, and look at the size. Femoral nerve will be present outside the femoral sheath, and it is not a content as we can see. And here we have this nerve, lateral cutaneous nerve of thigh, which is the nerve of myalgia. This branch will be the femoral branch of genitofemoral nerve, and these two structures will be femoral artery and vein. Now this medial compartment of the femoral sheath, what is this called as? This medial compartment of femoral sheath is called as femoral canal. Its outlet will be called as femoral ring. The whole compartment is the femoral canal. It's like that opening will be called as femoral ring. But what is the content? Can you tell the content of the femoral canal, dear friends? It is the lymph node of Cloquet or Rosenmuller. Lymph node of Cloquet or Rosenmuller. And what is the clinical importance of this femoral canal? Clinically, what we can observe here is the hernia. Which hernia? Femoral hernia. Now, femoral hernia is more common in male or female? Femoral hernia is more common in, we all know, answer will be female more than male. So femoral hernia is more common in female. Okay, if I ask you which hernia is more common in female, what will be your answer? Which hernia is more common in female, what will be your answer? Then answer will be inguinal hernia, not the femoral hernia. Is that okay? Why not? Because you see, as a whole, femoral hernia in general, it's a rare entity. It's a rare entity. But if you compare in male or female, so irrespective of sex, basically which hernia is more common is inguinal only. Okay? But if at all you compare only the femoral hernia, then it is more likely to occur in female. That is the only thing. Is that okay? But in general, the femoral hernia itself is a rare entity. It is not commonly encountered. So did you understand this point? So far so good, right? Now dear friends, we have made this diagram, that is the schematic one, but let me show you this particular diagram now, and if you can identify the structures with me. Yes, let us start identifying. Tell me, what is this muscle which I have put the arrow mark on? That is the sartorius. And these two muscles are coming from above. They are iliopsoas. I have already shown you the iliopsoas. You remember iliacus and psoas major, when they come down, they enter the thigh as iliopsoas. Do you remember iliopsoas? And on the pectineal line, this muscle will be pectineus. This muscle will be pectineus. And medially, this muscle is there, that is adductor longus. And this is the medial most muscle, that will be gracilis. Now dear friends, we know that boundaries are the sartorius is there, adductor longus is there, and the inguinal ligament there. Can you tell me which border of the sartorius I should take for the boundary? This is the lateral border, this is the medial border. For the boundary, I should take the medial border of the sartorius, correct? But which border of the adductor longus I should take for the boundary? Because one is the sartorius, another boundary is this, that is inguinal ligament. Now adductor longus, which border of adductor longus I should take the boundary? For the boundary, here again we will take medial border of adductor longus. So both are medial border of sartorius, medial border of adductor longus. Because if you take the lateral border of adductor longus, that will be your triangle. That will be geometrically, it will be triangle, that's true. But then in that case, adductor longus itself will be out of the femoral triangle. And that is not the described femoral triangle. For the described femoral triangle, you have to take both the medial border of the sartorius, medial border of the adductor longus. So what makes the boundary is more than clear. Sartorius, adductor longus, and the inguinal ligament. Who is there in the floor? These all four muscles are there in the floor. So iliopsoas, pectineus, and adductor longus itself is also there in the floor. So far so good, dear friends. So we have understood the inguinal ligament so far. Let me just summarize. We have spent around 22 minutes together, and in this time what we have learned lumbar plexus. We have identified all the branches in the given diagram, right? Then we have talked about the extensions of the inguinal ligament. We have seen the boundaries of the femoral triangle. We have seen the floor of the femoral triangle, and we have identified individual muscles also. Not only that, we have seen the compartments of the femoral sheath, contents of the femoral triangle, and the femoral canal, which is the medial compartment, and the relevant clinical anatomy, that is femoral hernia. So far so good. Can you give me quick feedback till now? Whatever we have discussed, is everything fine? Could you appreciate this much part? यहाँ तक हमने जितने टॉपिक्स कवर करे हैं क्विक मैनर में, एक कंसाइज वे में, वहाँ तक आपको सब क्लैरिटी है? मेकिंग सेंस? Yes. Now we will proceed and we will discuss the further conceptual understanding and the contents, like basically femoral artery, what are the branches, femoral nerve, like what are the branches, like those things. And also when we said femoral sheath, how the femoral sheath was contributed. Femoral sheath will be contributed by two fascias. Anteriorly, this is the fascia transversalis, which is coming down, and from behind, posteriorly, fascia iliaca, in front of the iliacus muscle. So fascia transversalis coming like this, fascia iliaca coming like this. So overall, they make the femoral sheath. So femoral sheath will be your contributed by two fascia, that is fascia transversalis and fascia iliaca. Yes, Janvi, let me repeat the femoral canal in the diagram. So now we are looking at the femoral sheath from above. When we are looking from above, we can see this is the medial aspect, this is the lateral aspect. Okay, in the intermediate plane we can see the femoral vein. Do you all agree? In the lateral compartment we have femoral artery and the femoral branch of genitofemoral nerve. Do you all agree? But this whole medial compartment, the whole medial compartment of the femoral sheath is called as femoral canal. Do you appreciate now? And it is having one lymph node of located as a content. And in the schematic diagram, if I show you in the schematic diagram, it will be like this. It will be like this. This thing that I have highlighted in the red color, do you appreciate? This will be the femoral canal, the whole compartment. But it's you can say inlet, or you can say the boundary, or that will be called as femoral ring. ठीक है बेटा, everyone, सबको clear हो गया? बहुत बढ़िया, शाबाश. Let us move further, and now we can see this particular part, that what are the contents. We all know femoral vein, artery, nerve, but the content will be in that format. Vein from medial to lateral, they are arranged in vein manner. Vein, artery, nerve. Okay, vein, artery, nerve. But if you can see, this is the femoral artery. This femoral artery is giving this branch, which is deep branch. Because it is deep branch, can I call it this as profunda femoris? Can I call it as profunda femoris? Profunda means deep, femoris means thigh. It can be also called as deep artery of thigh. This can be also called as deep artery of thigh. This profunda femoris will give one branch in the medial aspect and one branch in the lateral aspect. The branch in the medial aspect will be medial circumflex femoral artery, and the lateral aspect branch will be lateral circumflex femoral artery. What is the significance? You remember circumflex humeral artery. In case of humerus, when we study in the arm, we study the circumflex humeral artery, and there we use the term acha and pacha, that is anterior circumflex and posterior circumflex. In a similar manner, we have the circumflex femoral arteries, but we do not have anterior posterior. Here we have medial and lateral circumflex femoral artery, which are the branches of profunda femoris. Is that all okay? But important point is, this lateral circumflex femoral artery is the structure around which our nerve is dividing into anterior and posterior division, because our nerve is coming as a trunk. From above it is coming. On the way it will get the artery. So some fibers of it will be going in front of the artery, and some will be going behind the artery. So basically we can say femoral nerve is dividing into two divisions. Let me show you another diagram which will make it further more clear. And in this diagram you can see that we have lateral cutaneous nerve of thigh, which we have already discussed. But this is the femoral nerve which is coming lateral to the femoral artery. This branch is the profunda femoris artery. Profunda femoris artery is giving this branch, which is lateral circumflex femoral artery, and around it we have anterior division and we have posterior division. Are you understanding? Yes. So these circumflex femoral arteries, they are the major source of blood supply for the femoral head. They make the major source for the retinacular vessels, right? Retinacular vessels. Like if you remember, like we have, like this is the femoral head is there. This is the acetabular sheath is there, and then inside we have the hip joint. We have certain retinacular vessels which are going from here, right? They are going to supply the head of femur. Although we have one branch here, artery to head of femur, but in case of fracture of neck of femur, these retinacular vessels will be compromised and the blood supply to the head of femur will be compromised. If the blood supply to the head of femur will be compromised, it will lead to avascular necrosis of head of femur. So in old age, like anyway, the patient is having the weakness of the bone and the chances of fracture is high. Okay, and sometimes the history is given that fall in the bathroom leading to the fracture of neck or femur. What is the complication? Chances are there will be avascular necrosis of the head of femur, and they can now ask that what artery contributes to the retinacular vessels. In fact, both the circumflex femoral will contribute, but obviously the dominant artery will be MCFA, that is medial circumflex femoral artery. So if you have to choose one, without any doubt, go with medial circumflex femoral artery as the branch source for retinacular vessels. This part is clear. Can we come back? And also, have you understood the arrangement? Lateral circumflex femoral artery, around which we have anterior and posterior division. Yes. So now, dear friends, let us see what are the other branches of the femoral artery, and then after that we will study in detail about the femoral nerve. Okay. So when you look at the femoral artery, it will be giving certain superficial and certain deep branches. What are the superficial branches and deep branches? See, with respect to this ASIS, this is iliac spine. So we have iliac artery, superficial circumflex iliac, deep circumflex iliac. So one superficial and one deep artery with respect to this ASIS. Okay. Then we have superficial external pudendal and deep external pudendal. What is pudendum? Pudendum little meaning is shame, and it is used for the genitals. So for the genitals we have internal pudendal artery and we have external pudendal artery. For the external pudendal we have superficial branch, we have deep branch. They will be taking care of the genitals from the external aspect, but both of them are the branches of the femoral artery. And here I would like to ask this question: internal pudendal artery is a branch of. Let me see who can answer this. Internal pudendal artery. It's a branch of which artery? Yes, dear friends, internal pudendal artery किसकी branch है? Suddenly some of the students will be, यार इतना बढ़िया अच्छा फ्लो बना हुआ है, वी आर इन द femoral triangle, टॉकिंग अबाउट द फ्रंट ऑफ द थाई, ये कहाँ से pudendal artery आ गई? Yes, as I said, I am working on it. I'll be doing that. Beta Sonal and Nitya and the Neha and all other students. Very good. It is a branch of anterior division of internal iliac artery. Is that all okay? It's a yes. समझ आया सबको? Do you understand? All right. Again the random questions. Again random question. Superior rectal artery is a branch of, and inferior rectal artery is a branch of. Random questions. Superior rectal artery is a branch of, inferior rectal artery is a branch of. Superior rectal artery is a branch of inferior mesenteric artery. Inferior mesenteric artery will give this superior rectal artery. Inferior mesenteric artery means artery of hindgut. But internal pudendal artery will give this branch inferior rectal artery. Inferior rectal artery will be a branch of internal pudendal artery. And then there is a middle rectal artery also. Middle rectal artery is a direct branch from internal iliac. Okay, it's a direct branch of internal iliac. Did you understand now? All these parts are clear? All right. So far so good. Now coming back to the branches. So we have superficial circumflex iliac, deep circumflex iliac. Superficial external pudendal, deep external pudendal. Superficial epigastric artery is also there, but we do not have any deep epigastric artery. But then we have this branch, profunda femoris. Profunda femoris जो है, that will be profunda femoris will be the deep artery of the thigh, okay, and that will be giving the LCFA and MCFA, which we have already discussed. Also the deep branches are muscular branches which are going to supply the muscles. So those are the branches, right? But even though we have studied all, but the most important will be the profunda femoris, as well as this your MCFA, the branch of the profunda femoris with respect to the clinical application part. Okay, now dear friends, let us talk about this femoral nerve part. So we have ASIS, and this is what pubic symphysis, pubic crest and pubic tubercle. Between these ASIS and pubic tubercle we have the inguinal ligament, and from above we have this femoral nerve entering over here. And femoral nerve, when it is coming, it will be dividing into two divisions, anterior and posterior, with respect to one artery. The name of the artery is lateral circumflex femoral artery, and the name of the branches are anterior and posterior division. Making sense? What are the branches? If you see, when the nerve, this is femoral nerve, when the femoral nerve is about to enter in the femoral triangle, it is entering from above. Like from above, it will give one branch to the muscle iliacus and one branch to the muscle pectineus. But then it will give one branch from the anterior division to the muscle sartorius, and four branches from the posterior division. These four branches are the branches for like quadriceps femoris. Quadriceps femoris, like we have rectus femoris, we have vastus lateralis, we have vastus intermedius, and vastus medialis. And from the anterior division we also have two cutaneous branches. Which cutaneous branch? We have medial cutaneous nerve of thigh, and we have intermediate cutaneous nerve of thigh. So basically, how many cutaneous nerve of thigh are there? Any idea, beta? How many cutaneous nerve of thigh are there? We have three cutaneous nerve of thigh: medial cutaneous, intermediate, and the lateral cutaneous nerve of thigh. But the difference is, medial and intermediate cutaneous are the branches from femoral nerve, whereas lateral cutaneous nerve of thigh is a direct branch from the lumbar plexus. Do you appreciate this point? Do you understand? ये पॉइंट सबको समझ आया है? And if you remember, we started our today's class with the question myalgia, and answer was lateral cutaneous nerve of thigh. Do you remember? And what we have seen as a part of lumbar plexus. Is that okay? But medial cutaneous and intermediate cutaneous, these are the branches from the femoral nerve only. So far so good? All right. Now one more point that we should understand over here is this: the branch to rectus femoris is also additionally supplying hip joint, and branch to vastus medialis additionally supplying knee joint. In fact, all the branches to the vasti, like vastus lateralis, vastus intermedius, they will also go to join the knee joint, but majorly contribution is given by the branch of vastus medialis. But what is the significance of knowing this? See, sometimes patient can come to you with the hip pain. If the patient is coming to you with the hip pain, like it can be the local pathology of the hip, yes, or it can be the pathology of the knee, but the pain is referred. Yes, that is very much true. Or there can be both reasons acting together. That can be also one of the possibility. Same is true for knee pain. So whether the patient is coming to you with the hip pain or the knee pain, you must remember that it can be a local pathology, or it can be a referred pain, or it can be both. I hope everything is okay. So far so good. But then posterior division of femoral nerve. Posterior division of the femoral nerve has not ended. It will continue with the great saphenous vein. It will continue with the great saphenous vein, and in this segment it is called as saphenous nerve. In this segment it is called as saphenous nerve. So saphenous nerve is nothing but the continuation of posterior division of femoral nerve which accompanies great saphenous vein. So if you do any, venesection or any surgical involvement of the great saphenous vein, the saphenous nerve will be involved. So far so good. So that is about the femoral nerve. Okay, we have already seen the branches. Now let us identify the remaining muscles over here. Dear friends, few moments back we could discuss this is sartorius, these two are iliopsoas, this was pectineus, and this one was adductor longus, and this one was gracilis. But if you can tell me, if this is patella over here, just above and medial to the patella, what is this muscle? Just above and medial, this will be vastus medialis. Just above and lateral, what will be this muscle? Vastus lateralis. So we have made vastus medialis, vastus lateralis. And if you can tell me what is the name of this muscle? Yes. So write your answer in the chat box quickly. What is the name of this muscle? This muscle is not vastus intermedius. This muscle is rectus femoris. Now if this is rectus femoris, then where is vastus intermedius? That will be present at a deeper aspect. So to reach the vastus intermedius, we have to do the dissection. We have to reflect this muscle. So when you reflect this muscle, then only you will be able to see vastus intermedius. Let me clear this region and let me show you how this muscle will be seen. Now can you see and can you compare? Some of the muscles from here have been removed, but we still have pectineus, we still have adductor longus, we still have gracilis. Now this is the patella, this will be vastus medialis, this will be vastus lateralis, and now what is this muscle, everyone? This will be vastus intermedius. So far so good. Could you understand? But well, when we were trying to reach here, doing so, we have also seen something else. What is that? We have adductor longus here, we have vastus medialis here, but inside it looks like some empty space. So if I take a section over here, in the middle, the bone will be cut. That means femur will be cut. Yes. On one side, this adductor longus will be cut. Yes. On another side, vastus medialis will be cut. Yes. But in between, some fibrous tissue will be cut. Do you appreciate this fibrous tissue which are present over here? So what is this canal? This is adductor canal. Do you understand, beta? So now, if I take a section, in the section, everything will be cut. Everything will be cut. But for time being, I can ignore the rest of the structures. I can only focus on the adductor canal, where I have the femur is there, one side adductor longus, another side vastus medialis, and both of them are connected by the facial roof, right? So if I take a section, it will be like this. femur is there, vastus medialis is there, adductor longus is there, and the facial roof is there. Please confirm, dear students, everyone, have you understood the arrangement of the adductor canal? Because in the book they simply make this much diagram, but I have described you why this is there. Rest of the structures will be also present, but we are ignoring them for a while. And we can see inside our structure is femoral artery, femoral vein, and the saphenous nerve. And nothing, we know the saphenous nerve is nothing but continuity of the femoral nerve only. So the femoral triangle structures are continuing in the adductor canal. Can we say that? Yes. And also we have nerve to vastus medialis over here, and the sartorius muscle is overlapping over here. Yes. So let me further show you this part. Shravan Subramaniam, what I have told, see this part carefully, that if we take a section over here, this is the picture. In this picture, obviously when you take a section, in the center bone will be cut, no? In the thigh we have only one bone, that is femur. Femur will be cut, and on one side adductor longus will be seen, another side vastus medialis will be seen, and in between this fibrous roof will be seen. Do you appreciate now? And here let me show you this, where I am putting the arrow. This is the gap where we have femoral, where we have the adductor canal. And if I show you the continuity, these vessels, they are coming from above, no? These vessels, that is femoral vein, femoral artery, etc. But what is the significance? Significance is like, suppose, like in our house, suppose one of the tap is not working, okay? Then plumber will come and he will fix the tap. But before fixing the tap, he will first block the water supply, so that while this repair work is going on, the water loss should not be there. In a similar manner, a patient has come to you with the popliteal artery aneurysm. You decide to go for repair of the popliteal aneurysm. That is very much required, that's true. But in order to do so, you have to ligate the femoral artery, right? In order to prevent the blood loss. Do you understand, beta? Could you compare? So what is the site where you will choose to go for the femoral artery ligation? Now let me show you. One of the site is the femoral triangle, another site is the adductor canal. If you choose here point A, that is femoral triangle, then you have to do the meticulous dissection, and in very small space lot many structures are there which we have already seen. So more tedious dissection and very high chances of injury is there to the nearby structure. But if you choose this B, then what actually is there, it is overlapped by a muscle over here like this. But if you reflect the muscle, you don't have to cut it, you reflect the muscle, then you will see this fibrous tissue. Now you give the nick here and you separate, then you can see the blood vessels very easily, and then you can ligate them. Do you understand? So it is relatively easy procedure, and there is risk is very much minimal. This was described by a vascular surgeon named Hunter. That's why it is also called as Hunter canal. So far so good. Adductor canal, Hunter canal, or because it is in the like below the sartorius, third name is subsartorial canal. Yes, dear friends, everything fine? That is the diagram for the adductor canal. What are the structures present? Femoral vessels, saphenous nerve, nerve to vastus medialis, and also branches of obturator nerve. Now let us discuss this question. Which structure lies midway between the ASIS and pubic symphysis? Which structure lies midway between ASIS and pubic symphysis? That will be femoral artery. That will be femoral artery, and this is very, very important for us from clinical point of view. Why? Because you see many times, like if you are not getting the peripheral vessels, then you may have to go for the femoral vessels, and for certain procedures directly you require the femoral vessels. So what you will do, you will first locate in a patient where is the ASIS, you will locate the pubic symphysis, you connect a line and you take a midpoint. What is this midpoint called as? This is called as mid-inguinal point, not the midpoint of inguinal ligament. Because if you take ASIS and pubic symphysis, then you take midpoint, it will be mid-inguinal point. mid-inguinal point. But then there is something which is called as midpoint of inguinal ligament. Midpoint of inguinal ligament is when you have taken midpoint between ASIS and pubic tubercle, not pubic symphysis. So if you take pubic symphysis as a reference, then you take the midpoint, it is mid-inguinal point. But if you take pubic tubercle as a reference and then you take the midpoint, then it will be midpoint of inguinal ligament. But the question says between pubic symphysis, that's why answer will be femoral artery. So if you have to locate the femoral artery, you will be choosing this. And if you have to go for femoral vein, you will be going a little medial, right? Now, dear friends, we have covered this part. Let's have very quick revision, right? Are you all set for the revision? Let's have very quick revision, beta. So we started with this question, meralgia. Answer was lateral cutaneous nerve of thigh. After that, we could see the position that if it gets compressed, then there will be the features of nerve compression in the outer thigh. And then we could see that's a branch of the lumbar plexus, and we revised the lumbar plexus. The mnemonic was ilias gets late on Friday lunch, iliohypogastric, ilioinguinal, genitofemoral, lateral cutaneous nerve of thigh, obturator and femoral nerve. We also understood the lumbosacral trunk is there, but it's not a branch of the lumbar plexus. It is L4, L5 fibers joining with S1, S2, S3 to make the sacral plexus. Root values will be what? Iliohypogastric. So I से start हो रहा है L1. Genitofemoral 1, 2, lateral cutaneous 2, 3. Next two remaining will be both L2, 3, 4, obturator and femoral. But which one will be dorsal? Femoral will be dorsal even though it is present in the ventral aspect. Why it is present in the ventral aspect? Because of the reverse rotation. Then we came here and we identified all the structures. I hope you remember that we had here, this one was iliacus, this one was vas major, which was pierced by genitofemoral nerve. This is the bone sacrum and these are the lumbar vertebra. And then you could see this is this was T12 subcostal nerve, iliohypogastric, ilioinguinal. When the muscle was cut, nerve was also cut. This is genitofemoral nerve. In the lateral angle, we have lateral cutaneous nerve of thigh. This huge branch is femoral nerve. This is obturator nerve. For the obturator nerve, I said two important hints. One is the pelvic tumor. Second is the obturator foramen. It will be supplying the medial aspect of the thigh. Then we came here. First of all, we saw attachment of the inguinal ligament between ASIS and pubic tubercle. Then we discussed three extensions. Now, can you tell what are the three extensions quickly? Three extensions were lacunar ligament, pectinate ligament, and the reflected part. Do you remember that? After that, we put the muscles like sartorius and adductor longus. Which border? Quickly answer. Which border? Both muscle medial border. And then we discuss what is the content. To add the content, we added the femoral sheath. In the femoral sheath, we have the compartment medial, intermediate, and lateral. Now, you tell me, in the intermediate compartment, who is there? Femoral vein. Lateral compartment, who is there? Femoral artery, along with femoral nerve of genitofemoral branch. And the main femoral nerve is not a content. It will be outside. It is a thick, you understand? And towards the lateral angle, we have the lateral cutaneous nerve of thigh. Now you tell me, dear friends, we have the whole medial compartment of the femoral sheath. What is the name? The name of the medial compartment will be femoral canal. And its inlet will be femoral ring. What will be the content? The lymph node of Cloquet or Rosenmuller. But what is the clinical anatomy? Femoral hernia. Seen more common in female. Which hernia is more common in female? Whether male or female, more common is inguinal only. Femoral hernia is a rare entity. So all these things we discussed together. I hope you remember everything. Yes. Now, after that, I have shown you these bony attachments that where exactly these extensions will be seen. Now you tell me, beta, quickly, what is this ligament that I am showing you with this red color? What is this ligament? This is inguinal ligament. Inguinal ligament gives attachment on the pectineal line. What it should be? Pectinate ligament. In between, lacunar ligament. Third extension, that is reflected part. Now this is the diagram that we have learned, and we talked about the floor. We could see in the diagram iliopsoas, pectineus, adductor longus, they all make the floor. Then we discuss here about the femoral artery, and I described that it gives the profunda femoris, it gives the other aspect like superficial circumflex iliac. Deep circumflex iliac is a branch of external iliac artery. Okay, and then we discuss random questions. I hope you remember random questions also, because rectum have 3 rectal artery, but branches, they are coming from different branches like that. Okay, and then we talk about the lateral circumflex femoral, medial circumflex femoral. The clinical aspect was this: the fracture of neck of femur leading to avascular necrosis of head of femur, right? But then we could see that we have anterior division and the posterior division. Then finally this branch. Now tell me, femoral nerve, when it is coming from above, it will be supplying 2 muscles, iliacus, pectineus. It comes down, divides into 2 divisions. With respect to which artery? Lateral circumflex femoral artery. Anterior division supplies only 1 muscle. Which muscle? Sartorius. Posterior will supply 4 muscles. Which muscles? Quadriceps femoris. Do you appreciate? Now, along with this, the branch to rectus femoris will also supply which joint? Hip joint. And branch to vastus medialis will join which joint? It will also supply the knee joint. So it can be referred pain. Do you remember that referred pain theory? And the most important point, posterior division will not end. It will continue as what? It will continue as saphenous nerve, which accompanies great saphenous vein. Right? Then we talked about this, that we have the femur on one side, adductor longus on one side, and vastus medialis on one side. This makes a boundary for adductor canal. And what is the clinical importance? We can ligate the femoral vessels here in order to repair the popliteal artery aneurysm. Is that all okay? And then we discuss this diagram, that is nothing but the adductor canal. And then we discuss this question where I described what is the difference between the mid-inguinal point and midpoint of inguinal ligament. You tell me right now in front of you, this screen, it's discuss which point. Is it the mid-inguinal point or midpoint of inguinal ligament? It will be mid-inguinal point. It will be mid-inguinal point. But if I want to take midpoint of inguinal ligament, which landmark I will change? I will only change pubic symphysis. Instead of pubic symphysis, I will write pubic tubercle. Do you appreciate this? So far, so good. So that was all, dear friends, that we had to do today. That's my detail. That's my Instagram, Telegram, Facebook, and newly I have started with this channel, YouTube pay, and where I have put very small videos, 5-10 minutes videos. Those videos, topics were given by students only, where they were finding difficulty. So I have tried to make those topics little bit more palatable. So if you have some spare time, go and watch these videos, because out of 15 videos, maybe 1 or 2 will be helpful for you. Okay, so those 1 or 2 concepts will be always clear. Those will become clear for whole of your life. That means, and if at all you see you also find any difficulty in any of these topics, you also send me the message. I'll try to make that also palatable. All right, thank you so much, dear friends.